Hi, everyone, and thank you so much for allowing me to
35 degrees in. Yeah. That's the time, 45.
talk about my work.
I'll be careful around.
I think someone might be unmuted. A little bit about my work. So today I'm going to talk a little bit about a new paper that we just have under review right now called Factors Associated with Perceptions of Respect in Healthcare Settings. Just a little bit about me. I am an assistant professor here at University of Delaware in the Biden School. My primary responsibilities are in the Center for Community Research and Service. My research really focuses on health equity and racial justice, as well as the intersection of policy and children's health. And I am a methodologist, true social scientist. I work in qualitative, quantitative, and archival data with a special interest in complex measurement and data. A special thank you to my mentor and co-author, Dr. Syria Lang. She was my postdoc preceptor and who really taught me a lot around health equity and thinking about how we measure and talk about health equity, both in qualitative and quantitative ways. So I'll be giving a qualitative talk actually this afternoon, and this is more about our quantitative work. So just a few concepts before we move forward. Kimberly Crenshaw, I believe in 1998, she coined the term intersectionality, which talks about how there are multiple overlapping identities that define our place in the world. So beyond race and ethnicity, we have things like gender identity, class, language, religion, ability, sexuality, so on and so forth, correct? And it really helps you think about the ways in which we navigate. And in this paper, we're really talking about this concept of equity, and it's oftentimes conflated with the idea of equality, whereas equality is when everyone gets the same thing. So in this picture example, we see everyone getting the same tennis shoe. You can think about equality when we had the stimulus payments during the pandemic. Everyone got the same stimulus payment as long as they made under a certain income. Whereas equity is a bit different than equality. Equity is about meeting people where they're at. It's not giving them all the exact same size of or the exact same shoe in their right size, but instead thinking about the person in front of you and their needs. So when we talk about health equity, we're talking about how we overcome certain health disparities that have appeared within populations and how to meet those populations where they're at. And not just blanketing these populations and bringing in the ideas of intersectionality within this work itself. So if we're not going to blanket a population and say this is what Black health is versus Latino health versus white health, instead we need to start thinking about the texture within our populations and how heterogeneous our populations are. And so this study is really looking at what are the factors associated with perceptions of respect in healthcare settings within and between ethno-racial groups, right? So what does it look overarchingly between different ethno-racial groups? And in our sample, we have white, Black, and Latino respondents, but also within those ethno-racial groups, acknowledging that heterogeneity exists within our own ethno-racial identities. I'm a Mexican-American woman. I'm also very white presenting. So the ways in which I am received into healthcare spaces may be different to the ways in which my mom is received or my brother, who are much darker and much more ethnically identifiable, right? So with that, the main overarching research question of this study were, are there racial differences in how people perceive being treated in healthcare settings? And then also what factors are perceived with greater respect, because we know that feelings of respect and belonging lead to service and care utilization. So like I said, we were looking at individual level characteristics between groups and within groups. And our hypothesis was that minoritized persons are more likely to report lower levels of perceived respect in healthcare because of discrimination across multiple settings, right? We so often within the social sciences and within public health talk about social determinants of health, or how where we live, work, how we're educated, how historical policy, things of that nature help to shape our health overall and throughout their life course. So when we're talking about multiple health systems, we're talking about exposure to discrimination or disrespect in neighborhood settings, in school settings, and so on and so forth. So our data was derived from the Survey of Health of Urban Residents, which was a cross-sectional survey taken in 2018. We had about, I believe, 3,801 participants. This was a purposive quota sample, so there are flaws in the way in which we oversampled for people of color to get a more representative sample. And our statistical analysis, we did descriptive characteristics by race and ethnicity. Then we did a stepwise ordinary least square regression, where our outcome variable of interest was really looking at respect in healthcare settings measured from 1 to 10, 1 being the lowest amount of respect, 10 being the highest utmost amount of respect. In this data set, it's really interesting because it has a lot of data that is not often on health surveys. So it had the everyday discrimination scale on the Survey of Health of Urban Residents, which allowed us to think about the different ways in which folks encounter discrimination. So examples of that would be like, I feel like I can go outside. I'm not doing this question correctly, but to the effect of I can go outside feeling safe, right? Or I feel as though the way I dress doesn't expose me to discrimination. So it wasn't necessarily race-based questions. So in our first model, we just regressed perceived respect on race and ethnicity to see how people perceived respect in healthcare settings. Model 2, we added discrimination and indicators of material deprivation, so things like stress related to food, stress related to housing, so on and so forth. Our third model included socioeconomic and demographic characteristics, so things like gender identity, your age, your education level. And then our fourth model added in health status, which was a self-rated health status, and health insurance status, so whether public, private, or uninsured. And then finally, we ran the full multivariate model within groups. So looking holistically at Latinos, looking holistically at white people, looking holistically at Black people. Our probability level was a 0.05, and we did all of our analysis in Stata 16.1. So I got yelled at by a mentor because she was like, you need to break this down better. And so I apologize, but for lack of time, this is just our descriptive scale. So we had about 2,689, or about 70% of our sample was white. About 13%, or 1510, or 510 were Hispanic or Latino. And about 10% of our sample were Black or non-Hispanic Black, deriving a sample of 3,801. Some interesting things about the descriptive statistics were that Latinos, on just without doing any type of regression or anything like that, reported higher levels of discrimination than their Black counterparts, and white respondents reported lower levels of discrimination. And the mean discrimination score was about between where we would probably see it. And what else? Yeah, that's just one thing I wanted to point out, but we can definitely, if there were longer than 8 minutes, I would go through this more. So in our first model, we find that when regressing race on perceived respect in healthcare settings, compared to white respondents, Latinos had a significantly less perceived respect, and Black individuals also had significantly less perceived respect, nearly about 5 times of that reported by the Latinos, right? And so that's really interesting when you think about the descriptive statistic that Latinos had higher reported levels of disrespect, but when we just start regressing or looking at the relationship between ethnicity and respect in healthcare settings, it starts to diverge in a big way. Then when you bring in things like discrimination, which is a mean score, we see that discrimination is tied significantly to disrespect in healthcare settings. But when we bring discrimination in, Latino individuals no longer are significantly associated with perceived disrespect. Housing stress was not significantly perceived. Only a few were oftentimes being stressed out by housing and food stress was significantly predictive of decreased respect, feelings of respect in healthcare settings. And then when we loop in more sociodemographic factors, we find that older age is significantly tied to increased respect in healthcare settings, and that identity really didn't matter. Whether you, and our base group here were men, whether compared to men, you were a cis woman or a trans person. And then finally, we know that health insurance is significantly tied to increased perceived respect in medical settings, as well as self-reporting good or fair health. So this is just between racial and ethnic groups, right? And so when we look within groups, acknowledging that we have diverging identities outside of our race or ethnicity, it gets really interesting. So when we look at white individuals, if they perceive discrimination, it is likely tied to a decrease in perceived respect in healthcare settings. Similarly, when you look at things like good health, it's increases in perceived respect, and being insured increases in perceived respect. When we look at Black individuals, right, we still see this discrimination really being significant, and oh no, I repeated that. Sorry, this is supposed to be Latino. But we see, a significant tie to when you perceive discrimination for it to significantly decrease your perceived respect in healthcare settings. And some interesting things we look at among the minoritized group, the ethnically and racially minoritized group, is that things like education level is tied to increased respect among Black individuals, things like older age among Latinos, things like good self-reported health, right? And so really what we're thinking about here is that we hypothesize that Black and Latinx persons are more likely to report lower levels of perceived respect in healthcare settings. We found this to be true, but when you look at within group dynamics, you see that experiences of everyday discrimination were significantly associated with decreased respect across all racial and ethnic groups, right? So it doesn't mean that you have to be tied to a minoritized identity, but it means that it's more about your life experiences and the ways in which stigma has increased perceived disrespect in healthcare settings. Among minoritized groups, we also saw that educational attainment and economic security in adulthood were a significant influence in relational aspects of care, meaning that the better or higher economic status that you had or educational attainment you had, the more you felt respected in these spaces. And we have to think back to the fact that Brown versus Board of Education is only about 70 years old, right? And so we need to think about how past policy has really influenced this and influenced advantages. Another major finding of the study that I thought was really interesting was that Latinos, while they descriptively described higher levels of discrimination, it was Black individuals who had higher levels of discrimination that were more meaningful and tied to respect in healthcare utilization and health service use, right? And so what that says to me is that, or the way in which we interpret it rather, is that discrimination doesn't happen equally, right? It's not the same across groups just because you're a minoritized person. We also had several limitations within the study. Because we were trying to oversample folks in order to get a representative sample, this was a non-probability quota sample. And we also couldn't dissect down, due to the limited size of the Latino population, the different varying racial identities among Latinos, right? So whether you're Afro-Latino, white Latinx, indigenous Latinx. And so we weren't able to see how you present, right? Me being a white Latina, I present out very palatably and I get probably more respect than most folks. But we can't prove that in a healthcare setting because we didn't have the data for it. So basically, our conclusions here are different aspects of individuals' lives influence how they perceive respect in healthcare settings. Experiences of discrimination are not equitable among minoritized groups or among within groups, right? There are different factors that really predict how we perceive ourselves and how we are treated in healthcare settings. So why would we treat the same minoritized group the same? Or why would we measure them that way too? And then finally, we believe that future work should continue to explore within and between group differences because it tells us more about how health equity is being experienced within these spaces, and introduce metrics that examine things like colorism and social hierarchies within ethno-racial groups. Thank you so much.